Acromegaly is the name given to the clinical manifestation of excess growth hormone. Normally, the hypothalamus secretes growth hormone releasing hormone GHRH, which stimulates the pituitary gland to secrete growth hormone. The growth hormone then stimulates liver, skeletal muscles, and many other tissues to secrete insulin-like growth factor 1 or IGF-1. IGF-1 is directly responsible for promoting bone and soft tissue growth. IGF-1 also inhibits the release of growth hormone via negative feedback. The hunger hormone ghrelin also plays an important role in regulation of growth hormone, acting as a potent stimulator. What causes acromegaly? Excess growth hormone production can occur most commonly due to benign pituitary adenoma, a tumor in the pituitary gland. Rarely, excess growth hormone can also be produced by carcinoid tumors in the lungs or the liver, which act as an ectopic source. So, what are the signs and symptoms of acromegaly? Since the excessive growth hormone causes an overgrowth of tissues, patients can present with a large brow area, large nose, large tongue, widely spaced teeth, and a protruding jaw. There is also a general coarsening of the face and large hands and large feet. Acromegaly can also affect the heart tissue, causing left ventricular hypertrophy, and the blood vessels, causing hypertension. It is also linked to type 2 diabetes and colorectal cancer. Before we get into the next sign, we must know that a pituitary tumor can either be a microadenoma or the more common macroadenoma, in which case the tumor compresses the surrounding structures. The structure just above the pituitary gland is the optic chiasm, where the optic nerves carrying visual signals from the outer or temporal side of the visual field cross over to opposite sides of the brain. Compression of the optic chiasm results in the loss of vision from the temporal or outer halves of both eyes, known as bitemporal hemianopia. So how do you diagnose acromegaly? No, unfortunately, you can't just measure growth hormone levels in the serum because its production is pulsatile throughout the day. What we can measure is the level of IGF-1 in the serum, which is done as a screening test. If raised, we move on to perform an oral glucose tolerance test. Glucose normally suppresses growth hormone levels to less than 1 microgram per liter. In this test, if the growth hormone levels are greater than 1 microgram per liter, acromegaly is confirmed. An MRI of the pituitary gland can now be done to locate or rule out a pituitary tumor. So how do we treat acromegaly? Well, we just need to remove the source of the growth hormone production, whether that be a pituitary tumor or an ectopic source. Transsphenoidal surgery is first line for a pituitary adenoma. In cases where surgery isn't a viable option, medications can be used. These include pegvisomant, a growth hormone antagonist, octreotide, a somatostatin analog, and dopamine agonists such as cabergoline. Finally, radiotherapy is also employed for use as an adjuvant. Let's end this video with a question. Although the disease itself is quite rare, if excessive growth hormone production occurs before complete growth plate fusion, that is in the ages of 12 to 16 years in females and 14 to 19 years in males, it results in a syndrome coined differently as gigantism. What is the difference in signs or symptoms between gigantism and acromegaly? Long bone epiphyses still haven't fused at such a young age, so the most notable sign in gigantism would be tall stature. With that, we end this topic. I still have some more endocrinology in the works, so see you next time.